Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guests today are Cam Deemer, CEO at DrFirst, and Pooja Babbrah, practice lead pharmacy and PBM services at Point of Care Partners. Welcome.
Thanks, John. Good to be here.
Yeah,
Great to be here,
excited for the
John.
conversation. And, Pooja, I've known you on Twitter for a decade. Cam, we've had you on the show before. This is going to be an exciting conversation. Before we dive into today's topics, why don't you tell us a little bit about yourself and Point of Care Partners, Pooja?
Sure. Nice to meet everyone. Pooja Babbrah. I'm as I mentioned, the pharmacy and PBM practice lead. Point of Care Partners, we're a health IT consulting company. I usually do strategy engagements, and I always say we work at the center of health IT strategy and policy and standards. So that's why a lot of my work runs around standards, kind of what ONC is doing, CMS is doing, and others. So great to be here. Thanks for having me, John.
Yeah, thanks for joining. Cam, how about yourself and DrFirst?
Sure. Been with DrFirst now for just almost 20 years, John. It's been a really interesting ride. I did want to mention I started my health IT career at PCS Health Systems, a big PBM out in Scottsdale. That's where I met Pooja.
Wow.
We've been working on and off together for about 30 years now, maybe longer than 30 years. I don't know. You still look young though, Pooja. Thank you. Not
He
hard.
does. That is true. Well, time passes. We all get older. I feel that every day. But Pooja, let's dive in. You and I were both at the ONC annual meeting recently. Talk to us. What are some of the top points from the conference for our discussion today?
Yeah, well, I think the biggest one is QHINs are real, right? Anyone that got those T-shirts saying QHINs aren't real, those are going to be, something to hold on to. But I think a couple things, John, I know you and I ran into each other at the Clear and Care Alliance reception, right? And Care Alliance is all about patient access. So now that we've got different, the QHINs up and running, I think one of the biggest exciting announcements is the fact that the patient access, right? So now patients will be able to get their data. I think patient engagement is so important. As we start to open up data, and I know there's still a debate, right, about whether patients should really have their data, whether they shouldn't, and I think you and I have been exposed to enough of the patient advocates that are out there and attending these meetings to say how important it is, right, for patients to get their own data. So I think that's kind of one of the takeaways that I had and thought was exciting. The other one, which I know we're going to dig into a little bit more, is just who else besides physicians need, the patient information. And, both Cam and I are on the pharmacy side, and there's been now a big push over, 6 months or so, right? ONC, others that are starting to look at what we're calling pharmacy interoperability, which is essentially getting pharmacists more patient data. And I think that, we had one of the breakout sessions focused on the ONC recommendations, but also just, involving pharmacists and pharmacy in the care team. And I think, my takeaway from the ONC conferences, they're starting to get focused on that, which is really important.
Yeah. I mean, I would go stronger than you, Pooja. I'd say we know that patients deserve access to their data,
Absolutely.
and ONC is going to take every effort to make that happen.
Yeah.
And there's people
Yeah.
that are stuck behind and afraid for not valid reasons in most cases.
Yeah.
But yeah, there was a lot of talk of I think that was the interesting point for me at the meeting was how many of the various government organizations wanted access to this data, along with pharmacists, patients, et cetera, right?
Yeah.
CDC was represented, FDA was represented, all these different government organizations, CMS, of course, so that was a big takeaway for me. Anything you'd add, Cam, from the QHINs, or, interesting to dive into pharmacy interoperability is interesting as well.
Yeah, I think the pharmacy piece is very interesting. When you go back to the beginning of ePrescribing, pharmacy, for whatever reason, didn't really seem to have sorry, I'm going to say they didn't have a seat at the table. I'm sure a lot of people will say, no, that's not correct. They've been at the table the whole time. Well, they have been, but not sort of dealing with the actual issues that they need to deal with around electronic prescribing and interoperability. As an example, well, we're 30 years on now from when I first got exposed to e-prescribing. In those early days, it was all about get the script to the pharmacy because the pharmacy's got to fill it. Today, it's about get the script to the pharmacy because the pharmacy's got to fill it. You know, nothing's really changed. In spite of the fact that that whole 30 years, pharmacists have been saying, look, let me practice up to my license. Let me do the things I can actually do for the patient. But there are other factors that just haven't let that happen so far.
Interesting.
That's some of what I thought we might talk about. Just simple one. Just think about tradition and kind of the psychology of this space. People still don't view the doctor and the pharmacist, you know, in the same light. You know, the doctor traditionally is where the patient goes, gets their focus from. They go to the pharmacy to fill the script. The pharmacists have a lot more to add. You know, they would like to put their expertise to use, but how many patients really understand that that's even available at the pharmacy, let alone, you know, that they could take advantage of it? And even if they try, does the pharmacist really have a record of all their drugs? Because economically, traditionally, pharmacies haven't wanted to share that information or receive that information. Because if I receive it at my pharmacy, I could steal patients from your pharmacy because now I know drugs they're getting that I'm not filling. And if you get the information, you could steal my patients. So we've got to get past this old traditional thinking of, you know, roles are very regimented and that, you know, economically we can't afford to do the right thing for the patient. That's got to go away now. You know, we have to all be centered around really caring for this patient and let these other things sort themselves out.
It's interesting you say that. When I first started working in healthcare, I also worked with a pharmacy and implemented a lot of their systems along with the EMR and the clinical side. And the pharmacist pulled me aside. She said, John, when you fill your scripts, do it at the same pharmacy every time. I was like, why? She's like, because then they'll know every script you have. Otherwise, they won't, which is exactly the problem you're describing, right? She's like offering me a crappy solution to that problem. But like, you know, that shows how long it's been a problem. Pooja, what would you add as far as kind of like this early approach to e-prescribing, and it's kind of set the stage for where we're at today? Because to Cam's point, I mean, it is important to get the script to the pharmacist,
Right, yeah.
but there's more to it, right?
Yeah, and I agree with everything that Cam said. You know, we were both kind of in the early days, and you know, when SureScript started up, even before it was SureScripts, right? It was RX Hub, and you know, in addition to my role at Point of Care Partners, I am also on the board at NCPEP, and you know, as the chair of the board a couple of years ago, I started realizing, you know, pharmacy kind of gets left out partly because we've had these standards for almost 40 years now, right? Where we're sending the prescription to the pharmacy, that kind of works, right? The pharmacy submits a claim to the PBM, that works. But we're now seeing, as Cam mentioned, right, like these other roles that the pharmacist could be playing. And I think a perfect example is during the pandemic, right? We saw that pharmacists really stepped up to administer vaccines. They even, you know, were able to start doing test and treat. So, you know, we all cheered when the pharmacists were, you know, allowed to test for COVID and then prescribe Paxlovid. But that's my favorite example because the restriction that was put on the pharmacist is they could only prescribe it if they had access to the patient's lab information. And so they had to make sure that, you know, they had the certain lab results and their, you know, their kidney functions were okay. Well, as pharmacists, like, how do you get access to that, right? There's not always an easy way to do that. And so I remember sharing this story kind of at ONC and in other places, and people are like, wow, we didn't realize that, right? We're like, oh, great, we can now get Paxlovid from our pharmacist, but without them having the patient record, you know, and having that information, that access to that information, you know, it's great to say in name that you've got that ability to do that, but you've also got to give access to that pharmacist to do things. So I think, you know, Cam and I are kind of in agreement in terms of, you know, what is it that they need to make sure that they can step into additional roles besides just dispensing the medication.
So John, not to get too far afield here, but just going back to the QHIN issue, I mean, there's some very similar things there. You know, I'm kind of holding my breath to see where QHINs come out. You know, they're not the first attempt we've had at broad sharing of data. There's been private industry coalitions that have said that's why they were organized. There's been government approaches to it. And yet somehow we still don't have interoperable data sharing. Not even just the sharing part, let alone whether it's interoperable. So what are the QHINs going to be? Are QHINs just another way to protect one's own data? If you look at the folks forming QHINs, it kind of looks like maybe there's some protectionism lining up, but that'll be the test, right? Whether they are in fact what they are in theory, and whether they actually do make that data available. And we'll know very quick. We'll just look at the rules around how data is to be shared out, and that'll pretty quickly establish whether they are truly an answer to interoperability or just one more thing that we have to reinvent several years from now because it's still not working for us.
No, and I think that's what we saw at the ONC meeting was, you know, hopeful optimism that it will solve the problem, but also some question of, you know, the rubber's about to meet the road now that they actually are sharing, and how will they share? So I think you're right. We're going to see that pretty quickly, you know, how that's going to play out. Are there some things, Cam, that, you know, are maybe changing now? Some things to be hopeful about, especially when it comes to pharmacy interoperability?
There are. You know a little bit about our company. We work with about 300 EHRs. So we have a lot of opportunity to talk to them about the attitudes of their doctors, and we work with a lot of health systems too. So we get that kind of input. And what we're finding is that certainly in pockets of that part of the industry, physicians are starting to realize that, look, we've got our own shortage of staff. You know, we can't really handle the patient loads that we would like to, and it makes all the sense in the world to start to move some of that, you know, vaccines, some of the primary care functions over to pharmacists who could handle it out in the community, and then we'll take the people, you know, who really need our expertise. So we are seeing more of that. We're seeing again what looks to me a little bit like the patient-centered medical home kind of concept is coming around again. It's not the exact same thing, but again, the pharmacist is being asked to be part of an extended care team to provide the expertise that they have around, you know, drug load for the patient. And it's coming back again. But I think to me, John, this all ties back also into consolidation. The industry's gotten smaller in terms of the number of entities that have to cooperate. And the ones that are left, you're starting to see more advanced views of this, like breaking down some of those traditional roles and saying, yeah, I can see now where, you know, the folks on the other side have a role to play. And I think that's very hopeful. We're trying to lean into that pretty heavily right now.
Yeah, that's excellent. Pooja, what do you have optimism about?
Yeah, I think, you know, I'm starting to see a lot of pharmacies step up to fill that role. You know, there's CPESN, which is a clinic information network that is basically a network of community pharmacies. And what I've noticed is that, you know, they start out in North Carolina. They are now have networks across the nation. And it's essentially community pharmacists that have kind of grouped together to contract with health plans, right? And as Cam mentioned, you know, kind of play that role. I think what I've seen is kind of interesting because they changed their marketing slogan to be I think they branded themselves as like a pharmacy ACO. So you're starting to see, right, that shift of thinking of how can pharmacists fill more of that clinical role and really partner, right, with the providers. And that gives me some hope. I think there's now tools, right, that people can use in order to share data between pharmacists and providers and payers. But I do think, to Cam's earlier point, I think, you know, now the rubber's going to hit the road, right? Like, how much access do you give people? Is there still going to be some siloing? You know, are people going to be able to afford to, you know, connect to some of these networks to get this information? So it'll be interesting to see, but I do think, you know, I kind of left that meeting hopeful as well that, you know, at least we're starting to see some traction in that area. And, you know, with the QHINs and just more of this kind of rulemaking, right, of you have to share data, hopefully that'll help a little bit as well.
Yeah, absolutely.
Yeah, I was going to say another thing I think is hopeful is it's been interesting, the leadership that is in place now in the pharmacy community. Like I work mostly with the vendor side, not so much with the end pharmacist. But in the vendor community, we've been working closely with a handful of vendors now who particularly represent the independent side of pharmacy. And you can see their thinking is very different now. I mean, they're very results focused. So it's not so much, gee, I hope someday we get a place, at the table. It's more, hey, we need to give up a little of our protectionism in order to, let other people give up a little of their protectionism. So why don't we all just do that? Why don't we sit down, work out real solutions? And it's been very exciting. And I think this kind of plays into something Pooja probably knows more about than I do. But the ONC has been looking at the fact that the standards aren't enough and that it's time now to go beyond standards. I thought that was an extremely hopeful sign, actually.
Yeah, absolutely.
Interesting. Yeah, well, and ONC's made it clear they want information blocking gone. They want sharing of data, right? So that those messages are clear. It's whether they have the strength and enforcement power to be able to do it, I think.
Too much focus on standards, what that results in usually is that people's innovation is blocked. So if I'm on the pharmacy side, I want to stand up a primary care model, and I think, well, I can't really do that without access to med history and, patient diagnosis, maybe some labs, if I want to really do it right. Well, who's going to give me that? And where do they give me that in the current standard? People haven't built out to that degree yet. So the idea that business partners, like there's enough consolidation now that business partners can talk to one another and say, hey, I'm a pharmacy vendor, you're a physician side vendor. How about I do this economically for you and you do this for me in terms of data? And there's room for that now, which is very exciting because that's real interoperability. That's actual access to data, that you can use in the moment with the patient. And it's good that we're moving away from the idea that standards will solve those problems. That they only get us to sort of a lowest common denominator. Everybody can talk at a high level, but we need to now dig down into actual workflows and how we really make a difference for that patient.
Yeah, just to add to that, I mean, on the NCPDP side, I think we recognized that a couple of years ago. Of course, NCPDP is a standards development organization, but what we created over this past year is a work group that's focused on care coordination, right, and innovation, because we recognize that, yeah, standards can move data back and forth, but how do you actually then build that coordination of care, right? How do you bring those pharmacists in? So Cam is exactly right. I mean, the standards, we've have them, we're able to use them, but let's take that to the next level now. Really coordinating care and improving patient outcomes. And that's not just the provider, right? It's the provider, the pharmacist, and keeping the patient engaged in their own care, which, I think is an exciting time because I feel like kind of all of these things that we're seeing happening in industry is moving us towards that point now. So
yeah, that's a great point. You can't leave the patient out of it. They have they got a role to play too.
Yeah.
Yeah, well, and the patient needs to be active in it. No one cares about their care more than they do. So
exactly.
It's good to have them focused and a participant in the care, right? Which is key. Pooja, were there some other, key takeaways from discussions you had at ONC's meeting, maybe related to pharmacy interoperability or even access to data?
Yeah, I think the biggest one is, so ONC had put together, I think in like June or July, we started a task force under the HITAC committee, and it was focused on pharmacy. So it was pharmacy interoperability and emerging therapies. And so I was part of that, as well as, many members of the pharmacy industry were part of that, along with just the regular HITAC members. So we put out our recommendations in November, early November. So we did have a panel, and it was interesting because there were packed room, which I was excited about. You never know, when things are focused on pharmacy. But a couple of key takeaways, and I'm going to bring up a couple of things that I think people may not realize is, first of all, pharmacists are not recognized as providers under the Social Security Act, and so they cannot necessarily access data from an HIE. So even if we wanted to include them there needs to be a legislative change in order for that to happen. And, we kind of brought that up, a couple of the panelists brought it up, and it was like, I kind of saw some heads kind of shake, right? And I don't think people realize that. So that's one thing that, I think is really important that came out of the recommendations. I think, we just talked about patient, right? Engaging them in their care. And it was one of the panelists shared, we've been talking about how we have these standards and we've been able to do med history and things, but this person's family member had just gone through 2 weeks ago, in the hospital, going to a step down unit, going to a SNF, and, their experience, and this is someone who, knows the standards, does all that, medications were actually being either called in or faxed. And the worst that we heard was snail mail, right? They literally sent to one of the long-term care units their medication list by snail mail. And, it's just heartbreaking, right? I mean, Cam and I, we've been in this industry for 30 years and we're hearing that, medication lists being snail mail. So, I think the recognition, right, that there has to be some change, that, we can't keep moving this forward. And I think just the other thing around pharmacy is this idea of the QHINs, right? Where's pharmacy going to play? Is there a role? And is it going to be just another where, they say that they're sharing data, but there's still data that people can't access? And I think I'm kind of, waiting to see where that lands. But those are really kind of I would say from a pharmacy standpoint, kind of key takeaways from at least the conversations I was in at the ONC meeting.
Interesting. What's worse, a snail mail or a CD-ROM?
Oh gosh, I know.
When it comes to
They did.
interoperability.
Oh, someone who was it that mentioned the floppy disk? I think it was Mickey or someone.
Yeah, he said he had a stack of floppy disks with health records.
Yeah, exactly. I tell you.
Come
Yeah,
a
it's
long
just,
way though, right? We don't use
yeah, we
floppy
have.
disks anymore.
Yeah, that's true.
a
Although I
positive.
did hear a story once of someone saying that they handed their medication list to the taxi driver that was dropping them to the long-term care facility. And I was like, oh, no, don't tell me that. There has to be a solution, a solution for this. So, yeah.
Cam, what's your perspective on kind of this, the future of consumer engagement? We've talked about it a bit, throughout this whole discussion. And, as I say, like, are the patients even going to allow us to not do this and solve this problem? Will the outrage be too much? How do you see it?
We're in many ways, we're right in the middle of this right now, trying to understand what TEFCA is going to mean to our business, how it's going to work. There's so many details that just haven't been worked out yet. How do you know a patient's who they say they are? It's that thing about trade-offs, right? I mean, you can have really clean, easy data sharing, or you can have super secure, never make a mistake data sharing. And those things are very difficult to kind of balance, I think. But it's heartening because we're seeing on both sides, on the physician side of the equation, health systems, they're actually knocking themselves out now to try to find ways to communicate with the patient, to keep them in the loop about what's going on. Seeing the same thing on the pharmacy side, tremendous amount of interest in finding new ways to engage the patient, make sure they show up, enroll them in programs where they can get more service. One of the big problems with patients, I think, is they don't even know what kind of resources are available at the pharmacy. I mean, pharmacy, again, I might get beat up for this, but I think pharmacy needs a lot better sort of marketing footprint to say, look, we can actually do these great things for you. Because what I've heard from pharmacy is people don't even respect their appointments. You break an appointment with your doctor, you're in big trouble. You break an appointment with the pharmacist, who cares? I'll just go some other time. So just getting past that, treating them as professionals, making it known to patients what services they can provide is very important. But the interesting thing we've been finding is much of this patient engagement is being hindered quite a bit by branding. That, I as a health system am so intent that I've got to keep my brand in front of the patient and keep them only within my brand, not let them be swayed to go somewhere else, for their next service. That limits quite a bit in terms of what you're willing to share and what kind of problems you're willing to solve for the patient. Same thing on the pharmacy side, to the extent that I've got to hold you close, I got to keep somebody else from doing med sync for you, right? And getting all your meds filled at the same time at their pharmacy. So again, somehow there's just got to be a psychological change here to realize our brands aren't the most important thing. You know, holding the customer is not the most important thing. Serving the customer is, and let that be what brings you the customers, you know? So I don't know, that's asking a lot, but I think that's going to be key to change.
What do you think, Pooja? I mean, it's an interesting dichotomy because in some ways the brand of pharmacist is good because I don't schedule an appointment. I just go get it, right? Like I drop it off, do some shopping, grab it, right? I mean, so it's more convenient than the doctor, which I know is going to be hours, right? So I don't know but you know, have they communicated what they can do and how they can help me? You know, I think that's a challenge. How do you view kind of this future of consumer engagement?
Yeah, and I think the appointment thing is a really good point though, because I think I mentioned CPESN, right? Those community pharmacies, but what they are trying to do is hold some appointments so they can do blood pressure or check your sugar level or do a med sync, right? Like what medications are you on? Let's make sure they're all being refilled together, or let's optimize your medication, all of your medications, right? And pharmacists can actually do that review and get paid for it, but you have to make an appointment to do that. So it is interesting because there's a lot of pharmacists and pharmacies that want to do this because they can actually get paid for it. But to your point, right, if the appointment isn't kept, that's hard for the pharmacist to do. So I think that is, right, a great example of something where people just don't recognize what the pharmacist can do in order to kind of help with that. I think the other thing, the branding thing is so important, and I'm going to get on one of my soapboxes I've been on for a while is, price transparency for what a medication is going to cost you, right? And I think when you're talking about consumer engagement, to me, price transparency and actually getting that in the hands of the patient is really important because, you've got the health system, right, that Cam mentioned about they want to keep them in their system. The pharmacy also doesn't want to be like, hey, if you went down to the street, right, down the street, you can get that. So I think part of the consumer engagement is also making sure that the patient has the tools to do some of this comparison for even medications, right? And so, I know a pharmacy wants to keep their prescription at their store, but how do we make it easier for patients to be able to see not only what pharmacists can do for them, but also where they can get their medication for cheapest, because if they're not going to be on it, that's just going to, adherence is a big issue, right? And people ending up back in the hospital and having worse outcomes. So that's kind of my other thing on pharmacy that I think is so important in consumer engagement.
So let me jump back in on this one. Yeah, that's really interesting, Pooja, and you reminded me of another dichotomy we have here. For theoretically, for a patient to be cared for most completely, it would be ideal to just be at one pharmacy, one trusted pharmacist, the same way they treat their doctor, right? Like, for whatever reason, pharmacists are seen as much more interchangeable than doctors. And like my mom won't go to a different doctor, but she'll go to whatever pharmacy. That's not right. And you got to change that attitude if you're going to really do care. But it's not that easy because the way payment works for pharmacy drugs, the way the networks are set up and the way consumer cards work, it's exactly what you said. Pharmacy A might be cheaper than pharmacy B for this drug, but pharmacy C is cheaper for this other drug. And if a patient is seeking lowest prices, they're going to probably be using multiple pharmacies for multiple drugs. And then you add in inventory, because one of the real trials for a patient is I go to the pharmacy, I'm in the headspace to get my drug, and oh, we're out of that. And maybe they'll help you find it somewhere, maybe they won't, So knowing ahead of time whether it's in stock, and if it's not, when will it be in stock? Very important. But if I want it now, I'm probably going to go to a different pharmacy where it's in stock. So where consumer attitudes about pharmacy are just not conducive in some ways to actually getting them the kind of care they could receive from pharmacy. So I'm not, I mean, I actually don't have a solution. I'm just raising problems now. But somehow we got to, again, balance this issue of it's really hard to get everything. It's hard to get best price in stock. and consistent care and not bounce around as a consumer. So again, marketing, education, you're going to have to win hearts and minds if you're going to get patients to give up some of those things in order to focus on their healthcare. And maybe that's part of what the ONC, or probably not the ONC, maybe CMS, maybe they need to work on how the financial incentives work on the patient side to encourage them to not pharmacy jump so much. That's very difficult.
Yeah.
Well, and that goes back to the interoperability, right? If we know that they're going to pharmacy jump because they're chasing the cheapest price with which a lot of people do, then that makes the interoperability even more important. Pooja, what are you gonna?
Yeah, absolutely. And, it's funny because one of the ONC, the high tech task force recommendations was around inventory, and we had a couple of the patient advocates on there, and they're like, they're all on 5, 6, 7 specialty meds, other meds, and, just hearing their stories, right, of that inventory issue. It's like, how do you make sure that medication's available? So absolutely an important issue for sure.
Yeah. Well, any final, thoughts or reflections from either the ONC meeting or maybe the current regulatory environment, and maybe any insights, into what we can expect, kind of next steps we should take or that are being taken? Maybe Pooja, you could start, and then Cam.
Sure. Yeah. And, I guess for me, it's nice to finally see some movement, right, on pharmacy interoperability and pharmacy being included in the ONC meeting, the panel, all of that. I guess my caution is, we're kind of seeing this, but there's only so much ONC can do, right? If you think about it, their purview is, certification and information blocking. And so, if you do read the recommendations, a lot of it's like ONC should work with, CMS or HHS or other organizations, which is great. I do think in going into 2024, we're going to see some of that. I mentioned I'm on the board at NCPDP. We've already taken the recommendations and said, okay, how can we start to move things forward, and also just working with, other standards development organizations, right? We know that FHIR is being adopted, trying to be adopted at scale. How can we make sure that, of course, on the clinical side, the medical side, but also the pharmacy being included. So, final thoughts, but, especially for those that are listening that, whether on the medical side, the pharmacy side, let's work together to make sure that we are moving things forward. I think, Cam and I were going back and forth on text, I think it was last month, where we said, we've been in this industry, as mentioned, for so long, and it's nice to finally see, right, some of the things that we even tried back at PCS, 20 some years ago, we're finally starting to see some of that, and I'm hopeful that things will move forward, but still kind of taking a wait and see attitude. But I think for me, it's nice to finally see some movement for this.
Awesome.
I think from my side, John, I'm very excited about like this new type of thinking that I'm seeing come in on the vendor side, where they are much more, like I said before, solutions oriented. And they're bringing in some of that technology innovation mindset, trying to generate that into these older traditional models or these older markets where they work. And yeah, they're ready to talk to each other. They're ready to make deals. They're ready to find ways to actually treat the patient as a consumer the way they're treated in other technology, like tech forward, innovative sort of markets. So I think we're gonna have a lot of fun over the next few years as we see new people, see people try new business models, new relationships. And I think to some degree, we're going to see these problems solved a lot more than we have seen them solved in the past. I think, I don't think we said it here, but Pooja and I were talking, I think we got another decade probably before we really get this nailed down. But we can do a lot in 2 years. So
before we both retire.
Well, AI is not going to solve all of this because it's a classic healthcare problem, right?
Yes.
It's a business problem. It's not a tech problem. If it were a tech problem, then it would have been solved long ago. So it is interesting to see the evolution of some of those business models that now do make sense as they get larger, or as regulation, makes it business sense for them. So
yeah, absolutely.
Very interesting. Well, I've really enjoyed this. Pharmacy interoperability is you're right. I mean, I've published for 18 years and I've done very little pharmacy interoperability. So I appreciate you guys both coming on and sharing your insights and perspectives on this important topic. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcast applications. Thanks.